Our next speaker is Beth. Beth is a paediatric emergency physician who traipsed across the countryside of most of Australia when completing her training before settling in Perth. Beth's the medical lead for distress minimisation and neurodiversity at her local emergency department. Beth, thank you.
Thank you. So while a lot of us in the paediatric emergency department get pumped for a big trauma or a crashing resus, the reality is that most patients who come through the door won't need us to save their life. While our care won't need to be life-saving, it can be life-altering, as we have the opportunity with every patient we see to place them on a positive trajectory for future health engagement. So just as we have a plan and preparation for a can't intubate, can't oxygenate scenario or a chest drain, so there is great value in having a plan and a toolkit for when you see the distressed, scared or dysregulated child, which is most of them. As American civil rights leader Joseph Lowery said, "If you don't know where you come from, it's difficult to determine where you are. It's even more difficult to plan where you are going." And this applies to us in medicine, as history has determined our current practice and continues to help with our future trajectory. So let's start with where we are now. Imagine going up to PICU to see this little baby girl. She's day one post-hypoplastic left heart operation. She's had her chest opened, she's intubated and ventilated, she's got multiple lines in and is on a myriad of infusions to keep her sedated and comfortable. She even has her pink comforter blanket next to her. To see how we got here, let's go back in time a few decades to another baby who had an open chest operation. In 1985, Jeffrey Lawson was born. He was 25 weeks gestation, and along with other issues, he had a patent ductus arteriosus. He underwent operative management of his PDA, which at that point in time was an open chest operation. Unfortunately, he died 5 weeks later. While his mother Jill was mourning his death, she made a horrendous discovery. For that operation, he had not received any analgesia or anaesthetic, only paralysis. In her own words, Jeffrey had holes cut on both sides of his neck, another cut in his chest, an incision from his breastbone around to his backbone, his ribs pried apart. He was awake through it all. Premature babies scream as much as we do. Jeffrey's care was not an anomaly though. It was common practice at the time for infants to be operated on with only paralysis or possibly the addition of nitrous oxide. Jill advocated for change in this area, most notably by writing a letter to a medical journal in 1986, which brought the issue into public view. At the same time, research was showing the negative impact of untreated pain on infants, and in 1987 it was declared unethical to operate on infants without anaesthetic. So can you imagine undertaking this baby girl's operation without any anaesthetic? Crazy. So what do we make of this? Were the surgeons and anaesthetists of the time intending cruelty? No. The belief at the time was infants do not feel pain and there are significant risks to using anaesthetics and opioids in unwell babies. In hindsight though, I'm sure many of them regret the practice. Paediatric anaesthetist Frederick Berry said at the time, "They were doing it for what they thought were good reasons. You can question their methods, but not their motives." And thankfully, we have moved forward significantly in our beliefs and practices around paediatric pain and distress management. However, we can still do better. While our motives are correct, we need to be continually reviewing our methods. A stitch in time saves 9, or so the saying goes, and this can be applied to management of paediatric procedures and procedural distress, as what we do today can impact the health and experience and engagement of children for a lifetime. The impact of untreated pain and distress is both immediate, short and long term, and it is our role as clinicians to identify and treat both the pain and the distress. We need to be aware of our biases, both our own and medicine's, in that we often under-recognise and under-treat the pain and distress. So who here has been involved in a paediatric procedure? How about a needle-related procedure? Yeah, a lot of us. Venipuncture, cannulation are very common in the paediatric space and paediatric emergency department. We know though that needles are the single greatest source of pain and anxiety for families while in hospital, yet staff have contrasting viewpoints. Needles aren't that painful, quick is best, and to employ comfort measures will take too long. The disparity here is clear. So, Jack comes into your ED, he's got a suspected elbow joint infection. He needs a cannula for bloods and for antibiotics. He's taken into the treatment room, he's wrapped in a sheet, held down by 2 nursing staff, and his mum watches on. The immediate impact of his untreated pain and distress are that his heart rate and his blood pressure rise, he gets distressed, he cries, the stress rises in the room for everybody. He wiggles, he gets more distressed, that first attempt at cannulation fails. Ultimately, you do get your cannula in, but it's taken a long time, a lot longer than you would have expected. He now gets admitted to the orthopaedic ward, where he experiences the short-term outcomes from the untreated pain and distress from the ED cannulation. Whenever a nursing staff walks into the room, he starts to cry. He now associates the hospital uniform with pain and distress. It's difficult to get an accurate set of obs, and whenever they access his cannula for checks or for antibiotics, he becomes more distressed. At 3 a.m, his cannula tissues. He's been febrile for the past few hours, and he's due for his antibiotics. The night RMO gets called up to resite the drip, which is pretty new to peds, only been around a few weeks. As they go into the treatment room, Jack sees that sheet laid out on the bed. He's primed for the ensuing distress. His mum's starting to tear up as well. With the limited resources of the night shift, it is even harder than that first time back in ED. Jack recovers though, and he gets discharged from hospital. The association is now well established. He comes back into the hospital for his follow-up appointments and into ED for new ailments. Maybe he's been on the slide in Warrnambool. And every time he comes to the hospital, it now triggers behavioural outbursts. Jack grows up and he experiences the long-term impact of the untreated pain and distress from that first cannulation back in ED. He has anxiety, he has dysregulation of pain experiences and responses, and he has hospital avoidance. Jack is one of 25% of adults who has a fear of needles, most of which have been triggered by an event in childhood. So do you think Jack could be one of your patients? A child who you've cannulated or assisted on the cannulation for? Of note is the memory of pain intensity that most significantly predicts subsequent pain reporting. So the personal experience of pain isn't just about the degree of tissue damage, it's also related to the psychological and the social factors. Regardless of these factors though, that pain is real, and we have the opportunity to change that experience for that child and that family. Firstly, if we don't do the procedure, there won't be the distress associated with it. So the first question you always need to ask yourself is this procedure necessary? If it is, does it need to happen now? And in the paediatric emergency department, the answer to both of those questions is often yes. But we can approach it with subtlety and with nuance. So Zoe is 6 months old and she's got bronchiolitis. She comes into ED. She's got a mildly raised respiratory rate, but her other observations are normal. She's had pretty poor oral intake over the past 36 hours, and you're wondering about her hydration and her blood sugar. You ask the nurse to do a capillary gas, and you go into the next room to see another patient. The nurse comes up to you a bit later with the gas result. The sugar is 4, but the lactate is 3.8. It was a difficult squeeze. So you ponder this result. Zoe looks well. It's probably down to the difficult sampling, but can you be certain? Ultimately, you decide you need to go into the room, put a cannula in. The lactate's 0.7. Zoe gets some analgesia, suction of her nose, passes a trial of fluid, goes home with safety netting. But let's go back to the question. Did Zoe have normal blood sugar? You can answer that on a bedside glucometer. She had no red flags in her history or an examination for a more sinister diagnosis. So why did we do a cap gas? Well, it's easy. Depending on your role and where you work, you may not be the one who does it, and so it's a task that can be delegated. Surely the more information we get, the better. And the pain inflicted on Zoe doesn't impact us, except that it does. The cognitive load of an abnormal result that wasn't related to your clinical question, doing a cannula, and now you might be the person who cannulates Zoe next time she comes in, and depending on how it went today, we'll have her primed for that next experience. So extra time, resources, and pain were the result of an unnecessary test. So bloods may be required, but let's have a think about the best way to do the sampling. Capillary bloods are more painful, despite the use of EMLA, more likely to fail or produce spurious results, and they don't offer you a route for medication delivery. Conversely though, if you've got a chubby yet pale 6-month-old, it might take you several cannula attempts, yet a capillary blood will be able to give you an accurate haemoglobin. Similarly, do you need to place a cannula, or is venipuncture enough? Again, often in the ED, we're looking for things to treat and we'll need the cannula, but it's worth thinking about. So now that we've decided our procedure is necessary, let's engage our tools to minimise distress and pain. So let's go back to the 1980s again to another health advocate. So Mary Barkey was a child life therapist, and in the early 1980s, she questioned the practice of child restraint by multiple adults to facilitate IV and nasogastric insertion. She questioned the normal practices of the time, and she brought about positive progress. She asked, why are we traumatising our children like this? Isn't there a better way to do these procedures? She was a key instigator in comfort hold positioning. Stefan Friedrichsdorf, who's now a paediatric pain specialist, had a similar reflection in the 1990s when he was a medical student. Hospitals claim that they never have enough staff to provide appropriate pain control to children, but they always seem to have enough staff to hold children down. Despite the questioning and research that's taken place over the past 40 years, unfortunately, restraint is sometimes still used, but we can be the advocates for change. So being wrapped like a burrito is acceptable in one of these situations: to keep the chicken and salad safely in my tortilla to get it to my mouth. Burrito wrapping a child for a procedure, however, is a no-go. Let's look at what the alternatives are. Stefan Friedrichsdorf, the medical student who in the 1990s was shocked by restraint practices, went on to become a paediatric pain specialist. He worked at Children's Health in Minnesota, which is a health service that does over 200,000 needle-related procedures every single year, and his team determined that they could do better. They introduced the Children's Comfort Promise, which is a bundled approach offered to every child who undergoes a needle-related procedure. The 4 aspects of the bundle are sucrose, or breastfeeding for the appropriate age group, topical anaesthetic, comfort hold positioning, and distraction. Culture shift takes time and it takes patience. They were able to offer this bundle to more than 75% of children within 2 months, and now they continue to have greater than 95% adherence in offering this bundle to every child who needs a needle. And how encouraging is this? If a health service of this size can achieve this, so can we. We promote a similar approach in Perth Children's ED as well. So sucrose is a sugar syrup, and it minimises the observable features of distress, so can be useful in painful procedures. It's more helpful with a dummy as it helps to provide non-nutritive sucking, or a mother can breastfeed if they prefer. You need to give the first part of the dose 2 minutes before the procedure starts, and then small amounts just before and during the procedure. It's most effective in kids less than 6 months of age, and particularly in neonates, and been shown to be more effective than EMLA in the under 3 month age group for IV access. Topical anaesthetic comes in a variety of preparations, so check what you have available locally. EMLA is commonly used, and it's a eutectic mixture of lignocaine and prilocaine. It's licensed for use from 37 weeks corrected gestational age, however, does carry a risk of methemoglobinemia, so be aware of how much you use, for how long, and other predisposing risks. In older children, it takes a minimum of 60 minutes to have effect and can take 2 hours to have the full anaesthetic effect. It also requires an occlusive dressing, so in the adhesive adverse child, use a different product or cover it with cling wrap. Elemex is a 4% lignocaine cream, which is licensed in Australia for use from 1 month of age. It takes effect after 30 minutes and doesn't require a cover. It's more efficacious with heat, so rub it in for 30 seconds and then put another layer over the top. Comfort holds have replaced the practice of wrapping and restraint. Under 6 months, it's a normal comfort measure for children to be swaddled, and so this is appropriate in this age group. From about 6 months of age though, children prefer to be upright. When you are flat and you are restrained, it increases your distress, your heart rate, and your blood pressure. This increases the stress for everybody. And also, to be wrapped and restrained increases your distress time period from before the procedure starts until after that IV is secured. Being upright provides a sense of autonomy. Being held by your parent provides comfort and support. And a comfort hold can minimise your distress time period from potentially just the application of the tourniquet and the insertion of the needle itself. By spending an extra minute or 2 to educate the parent and prepare your team, you can have an optimal first attempt and overall save time. One of the key things of comfort holds is that you need to have a stable parent to have a stable child. It's the parent's role to hold the child's body and other limbs, and our role as the staff to immobilise the limb that we require. So let's have a look at a couple of these. So back to chest is a very common position. It's used for upper limb IV insertion, IM injections, hand and arm procedures. If you recline the bed back a bit further, it's good for ENT procedures, facial procedures, and nitrous application. You need to have that top of the bed quite upright so that the parent is supported and not rocking with the child. The parent is holding the child's other limb and his body, and his legs are enclosed between hers. Ideally, I'd have him sitting up a little bit more because having the hips flexed will minimise the kid pushing up. Both your proceduralist and assistant need to be braced so that you've got a stable limb that you're trying to cannulate or whatever procedure you're doing. We often pile blankets up adjacent to the parent's thigh so that you can rest and be braced. Also have a discussion about whether the child is going to look or whether they're going to look away. Just bearing in mind that kids often will want to observe at some point during the procedure, and that's okay. Another hold is the koala hold or chest to chest, and this is a natural and familiar position for most parents and children. This can be done on a bed or a chair and is good for your upper limb as well as your lower limb procedures. Once again, the parent's back needs to be stable, so position the back of the bed if you're doing it there. The parent is again holding the child's body and other arm, and her arm could be going over the top of his, and his legs are around her body. The assistant and the proceduralist are braced again and being held in a comfort position. So these comfort holds are not a panacea, and they do need practice and time. There are physiological and psychological benefits to them, and I believe they should be our baseline standard of care for any procedure or assessment requiring a bit more support. And then there's distraction, and this is important for all ages. I like to discuss comfort holds and distraction at the time of topical anaesthetic application so that the parents and family can have a time to think about what will work for them. We've got tools for young infants right through to adolescents, from rattles to VR goggles, and of course the ever-handy and ever-present mobile phone. And then we also have an extra component that we use in our department as our bundle, which is sedation. Use your above modalities, but if they are not effective, do not increase your level of restraint. If you can't delay the procedure to have more time to prepare, consider the addition of sedation. We know that 70% nitrous for 3 minutes is an effective dose before IV insertion, or clonidine or midazolam are other options as well. Try to bring in the use of sedation before the child gets too escalated, but you need to bear in mind the safety and logistical factors for both the child and your department. So these 5 aspects make for a really good foundation for procedural support. But there are lots of other adjuncts, so from buzzy bees, hush music, ultrasound guided IV, parent and child coaching, cognitive behavioural therapy and hypnosis. There's lots more to explore once you've got a good foundation and enthusiasm. Neurodiverse children are a special patient population who are frequent attendees to ED. They're at high risk of dysregulation in our department, and so we have created a neurodiversity care program to help address gaps in their care. We have a neurodiversity care plan, which the carers complete in conjunction with the child to help guide our care of their child. This can help improve the positivity of their experience from before we even set foot into their cubicle. It helps to guide our interactions because it's got questions regarding communication, medical examination, medication administration, procedures and interventions, the child's likes and dislikes, and how to help support them through their distress. We also have social stories. So these explain common ED experiences in picture and word form. We've got several of them, which include coming into ED, taking medication, doing a urine sample, having a cannula done. While they are designed for the neurodiverse population, they are effective for a lot of our patients. We also have sensory tools, and these aid regulation through descending neuromodulatory pathways. We have fidget poppers, pinwheels, sunglasses, earmuffs, wiggle cushions, and weighted blankets. And this is a picture of our sensory equipment room. So we've got our neurodiversity care program elements, we've got colouring in, we've got our VR goggles, our distraction trolley, our comfort hold posters, and our portable nitrous. By keeping the different elements together and within the clinical space, we can increase the uptake of the individual components. So what is routine for us in paediatrics, or in the emergency department, is scary and difficult for children and their families. It is time for us to change the narrative and let their perspective be the starting point for our interactions. When we ask our colleagues to change practice, it can be perceived as being told, "I am wrong." However, it's less about our old practices being wrong and more that we have a newer way to do things, just like we no longer operate on infants without anaesthetic. So this is an image of the Knaupen silos, which are a few hours south of here, aptly named Hope for the Future. There's lots of great paediatric places taking place around the country and around the world. And as we continue to share with each other, we can move from acting in silos to being an ever more connected network. We can achieve more together and ensure that wherever a child presents, they receive holistic and high level of care. So let's return to Jack with his septic elbow. Let's rewind our day and go into that cubicle with a new set of skills and a renewed focus. He's had Emla on for 90 minutes and there's been a preparatory discussion with Mum. He has a koala hold while watching Bluey and the IV goes in first attempt with just a few tears. A much happier boy gets admitted to the wards and you have altered his lifelong trajectory of care for the positive. And sure, it's not always going to be this straightforward, but today it is, and that is worth celebrating. Thank you.
Thanks, Beth. Before we get to our first question, I had one, and I have the stage, so I get to ask it first. I'm curious about when the parent can't hold the child, either because they're really distressed or because what's going on for the child. Is there anything that you've learned or that you use in your department in those circumstances?
Yeah, so there are times where parents can't hold, and I think now that we don't have the same restrictions compared to the height of COVID, often there are two parents and there may be one who can. But that won't always be the case, whether they're 38 weeks pregnant or distressed by what's going on or otherwise. And so my view there is that we don't go back to the practice of wrapping and restraining, but we have a chat about what we can do instead. And certainly in our department, a staff member can hold the child if the parent can't, and this just needs to be in line with your clinical holding guidelines and very much with parent permission. You don't get the same comfort effect from that, of course, but you are getting some of those physiological improvements, and it is still a hold of comfort rather than a hold of quite the same level of restraint. And if possible, keep the parent in the room so that they can provide a bit of touch and positive support as well, and to reassure the child that this person is safe. Yeah.
Any questions from the audience? Thank you.
Sorry, I'm Caroline, a rural paediatrician. It was actually just a comment. Thank you for an excellent talk around the pain minimisation. It was just a comment. There is a resource called Say Less, Show More, if anyone just types that into their search engine, and it is visuals for almost every PrEP procedure for both children and for adults who have intellectual disability or autism, and it's designed sort of more around that mild to moderate severe end of the spectrum. Mild to moderate end of the spectrum, so a single picture per page, and goes through each step of the procedure. And just a plug for people to use it, it is life-changing for kids with autism, particularly if they've had PrEP. I'm in ED, it's not possible, but in situations in paediatrics when we're bringing them in for elective bloods, if they've had PrEP over a couple of weeks prior to the procedure. But even in emergency, if you can say, I'm going to be back in an hour, and you give them a hard copy of that, and they can start rehearsing it, and you keep using it as you do the procedure, you keep referring to it, you'll have a child who's no longer so distressed that they can't even regulate it at all, to one that'll actually tolerate the procedure.
Yeah, thank you. And we're looking at getting our social stories on the internet so families can access them before they come in. And we also have a PDF of our resources, both the distress minimisation and the neurodiversity care program, if anybody wants a copy.
Another question from the audience?
My question is, do you have any strategies for oral medication? So obviously it's not painful, but the distress around that for some children.
So my first go-to isn't oral, is nitrous a lot of the time, because in ED I want something that works quick, wears off quick. And then from there, I've probably used more midazolam than I have clonidine, but certainly in discussion with my colleagues, finding that clonidine is quite effective from that distress viewpoint, but both of those medications you need a bit more time.
Thank you. Sorry, what about administering oral medication?
Oh, sorry, yes. I thankfully work with a lot of expert paediatric nurses who are really great in this area. Some of the things involve getting that syringe back past the tongue so they can't taste it as much. So midazolam being bitter, if you dip the syringe into apple juice beforehand but not aspirate, then they can get that taste first when you're popping it in, or making sure you've got a chaser of apple juice or something else to follow. But I think we've all found that I don't think there's a magic answer to that, and it's time and patience and work with the children. And there's lots of different strategies, and I don't know if anybody else has a winning solution.
Might have time for one further question.
Chocolate icing works wonders.
Chocolate icing, excellent.
press something? How did you go with persuading staff who may have been sceptical to some of these ideas and are slightly resistant to change?
Yeah, so thanks. Going back to like Stefan Friedrich Dorf's work with their comfort promise and that concept, it takes time and it takes patience. And so I do education sessions every term for the RMOs, every term for the registrars. I've done over a dozen nursing education sessions. We've had consultant CPDs around it as well. It's about bringing people into the model of what we're doing and why we're doing it so that they are part of your team and we're not against each other in making change in our department. And when people start to see it work and understand why, and they get that positive reinforcement, it really makes a difference. And yeah, having parents feedback how well it worked and celebrating those positives, as we were talking about yesterday as well, and always talking about it. So if I go into a room and I've seen a sheet on the bed, hey, what did we do last time? All right, how about we give this way a go instead? And then following up and also offering support. So going, has anybody tried it? What has worked? What hasn't? And then I can go into the room or have a chat with them and go, yeah, I can see why that would be difficult. How about we give this a go? And then we also have our K-Kind team of occupational therapists who can come down and support us during weekday hours, who are the pros with this stuff. Because if we can bring them in, it's less of a, I guess, cognitive load and learning for our staff to be doing it on top of their normal practices. And then we can observe what they're doing so that at 3 o'clock in the morning, you've got your skills ready to go.
Beth, thank you so much for your talk. Finally,